हाँ एकदम क्लियर। चलो।
Good morning, everyone. I'm Dr. Abhishek from India. Thank you, Dr. Abid and Dr. Marjana, for this opportunity and to highlight most important aspects of lung cancer care, which is often ignored. I shall be talking on prevention screening of lung cancer. Apart from this, I shall also be talking about environmental and occupational determinants of lung cancer, which is adding significant number of new lung cancer cases, and especially in relation to the developing nations, this is gaining importance. So I have nothing to disclose for this presentation. Coming to the risk factor, if you want to plan for the prevention and screening of lung cancer, you need to be well aware about the risk factor for lung cancer. If somebody asks you what is the risk factors for lung cancer, everybody will come with the answer. It's tobacco, tobacco, and tobacco, which is a major contributor to the lung cancer. It includes passive smoking and the other aerodigestive malignancy, which is caused by smoking, and COPD, which is commonly seen with the use of smoking. Apart from the tobacco use, other exposure to asbestos, radon, polycyclic aromatic hydrocarbons, chromium, nickel, inorganic arsenic are important risk factors which may cause lung cancer after chronic exposure for the longer duration. All the genetic predispositions are very rare, but many of the studies has found the correlation of various germline mutations, various uh, chromosomal abnormalities in relation to familial lung cancer, or it is also important for the COPD, which in terms is an important risk factor for lung cancer. Many of the people ask, what is the relationship between smoking and carcinoma lung? This is a very important information for the smokers who ask this question. So for more information on lung cancer, keep smoking. When one day will come when you will be very well aware about the management, biology, and the suffering of this disease, when at the personal level you have to undergo all the treatment modalities when you are diagnosed with the lung cancer. So as I told, now we see many of the young people are coming to our outpatient department, our clinics, and many of the female who are non-smoker are coming with the diagnosis of lung cancer. So you need to think what are the reasons that they are being diagnosed with lung cancer at early age. So passive smoking are killing 600,000 people every year as per the estimate, and this is very very bad figure. So the best way to avoid this is the avoid the company of smoker. This is a slide which tells you about the real world experience, and everybody and every smoker need to well aware about this. What we see in advertisement is a very impressive smoking patterns which is seen in advertisement. What we see as an oncologist is the actual reality, which is very horrible. So smoker needs to decide what are the things they want to live in their rest of the life, whether advertising is just a brainwash that is seen on the television, but actual reality is very bad. So role of prevention in this presentation, I will be talking about the primary prevention for lung cancer, which is a health education, and secondary prevention, half of the secondary prevention, early diagnosis through screening. So screening in lung cancer, these are the modality which has been used for screening of lung cancer: chest radiography, sputum cytology, low-dose CT scan. Biomarkers is the new thing which is we are finding to detect lung cancer at the early stage in serum, sputum, and bronchial wasing. Chest radiography and sputum cytology are no more a modality for the lung cancer screening because it failed to reduce the mortality from lung cancer. So standard is low dose CT scan. So there are, if you talk about the lung cancer screening with chest radiography, with or without sputum cytology, there are a number of RCTs, and there were RCTs from Memorial Sloan Kettering, John Hopkins, Mayo Lung Project, and one study from the Czech Republic. This all studies fail to give the mortality benefit when you use this modality for the lung cancer screening. So this is no more use. So there was another study, which is prostate, lung, colorectal, and ovarian randomized trial, which was done, to see whether chest X-ray was used as the screening modality for the lung cancer, and annual screening with chest radiograph did not reduce lung cancer mortality when it was compared with the usual care. There are various studies which shown the efficacy of low-dose CT scan. It was single low-dose CT studies for the lung cancer screening, and this all studies has shown very positive result that low-dose CT scan is very useful modality to detect lung cancer at early stage, but none of the studies has shown the mortality benefit from screening of the high risk individual using low dose CT scan because of the lack of longer follow up period. So this is another study which is very famous, done by JK Phil. It's a UK lung cancer pilot screening trial, which was done in approximately 250 individual between 50 to 70 years. And this trial demonstrated that it is possible to detect lung cancer at early stage and deliver potentially curable treatment in over 80% of the cases. When they analyze the health economics, which is very important, and it is always said that screening should be cost effective, and they came with a suggestion that this intervention would be cost effective. So this trial really changed, the screening modality and established low-dose CT scan as a standard screening modality for lung cancer. This was a trial, NLCT lung cancer screening trial, which was done in US, and it enrolled almost more than 50,000 persons in 33 US medical centers. So this is eligible participants were between 55 and 74 years of age, had a history of cigarette smoking of at least 30 pack years, and the participants were randomized to undergo 3 annual screening with either low-dose CT scan or single view posterior anterior chest radiography. When we saw the result, the positivity rate for the screening positivity was much more higher in the low dose CT arm. When we talked about the lung cancer total cases, it was again high in the low dose CT scan arm, and it is very important to get the mortality benefit, and especially in this lung cancer screening trial, we saw that 247 in LDCT versus 309 deaths per 100,000 person years in radiography group. So this shown a relative reduction in mortality from lung cancer with low dose CT screening of 20%. So that established the role of low dose CT scan for the lung cancer screening. There was another study published in New England Journal of Medicine. This study talked about the screening with low-dose CT scan in the high-risk individual at 1 year, 2 year, and 4 years. This took a very important consideration. They evaluated the non-calcified nodule, and they measured the volume, and they took the increase in the volume, or the volume doubling time. So they concluded like that initially the initially screen negative patient, when they were again screened for the first year and the second year, with this estimation they found that 1 in 1000 and 3 in 1000 people were detected with the lung cancer at an interval of 1 and 2 years respectively. So Nelson study is a very important study. This is a study by the Dutch Belgian randomized lung cancer screening trial. This was done with the high risk individual, and it was compared with the no screening. So they have an estimate of decreasing the lung 10 years lung cancer mortality by 25%. When they finally presented their data, they have clearly shown that yes, in the male there was a 26% decrease in the mortality of the lung cancer with the use of low-dose CT scan, and this was very high in in female, and it was 61%. So this is a summary of the landmark lung cancer screening trial. We have already, discussed about the National Lung Screening Trial, Nelson, and the UK Lung Screening Trial. So there are many others, which is lung screening study, and Danish trial, and there's a lung cancer screening intervention trial, DANTEN, the Brazilian trial. Apart from, two, except for the two trials, all other trials shows the benefits of the, doing low dose CT scan as a screening modality of the lung cancer. But Danish trial and the Dante, which could not show any statistically significant effect of low dose CT screening on lung cancer mortality. See, this is again ongoing lung cancer screening trial in developing nation, and you can find most of the studies are, undergoing in China, few are in Taiwan, and one study in Russia and the Kazakhstan. So in China, most of the studies are using low dose CT scan, except for the two. They're also testing, circulating DNA as a biomarker to detect it early. Kazakhstan is also conducting one study about the circulatory tumor, circulatory DNA to detect lung cancer at early stage. So this is summary of lung cancer screening guideline, which is adopted by various countries, and many important cancer-related organizations, starting from the American Academy of Family Practice, American Association for Thoracic Surgery, American Cancer Society, and most of the society advocate to go for the lung cancer screening at starting from 55 years of age to 80 years with a smoking history of 30 pack years. And they, anybody who is a current smoker or quitted smoking within last 15 years, and they all have recommended the annual low dose CT scan. Recently, probably what was the last recommendation by the US Preventive Services Task Force, it was, changed in the updated in July 2020. Initially, it was said that screening should start at 55. Now they have reduced the age to 50, and they now recommend that screening should be from 50 to 80 years. Initially, it was this high risk people with a smoking history of 30 pack years. It has now reduced to 20 pack years, and a screening should be discontinued when a person has not smoked for 15 years or develop a health problem that substantially limits life expectancy. So, harm of detection and early intervention and treatment. A modeling study performed for the US Preventive Services Task Force estimated that 10 to 12% of screen detected cancer cases are overdiagnosed. There are radiation harms, including cancer resulting from cumulative exposure to radiation, vary depending on the age at start of screening. So, what is the best practice for the lung cancer prevention? So one is secondary through the screening, which helps you to detect early diagnosis of the lung cancer, but it is very difficult to implement in community level, especially in the developing countries, because it is not a practical modality to invest so much money on lung cancer screening where you have another health issues to resolve. TB and other chest infections are so common, so it can lead to overdiagnosis. And if you think about the diagnosis of screen positive patient, it is a very resource intense, procedure, and you have to use all your resources. And at the patient point of view, it is also very, they affect the psychology of the patient, and it is not a very cost effective modality. So everybody must focus on the health education, and the ultimate key to success is the behavioral modification and effective anti-tobacco campaign. Coming to the environmental determinants of lung cancer, these are the various risk factors which has, exposure limits has been defined. So if somebody, is exposed for the longer duration and they are exposed, above the limits, they might get, lung cancer in the future. There are strong scientific evidence to support the association between these risk factors and lung cancer, although there is a variation in the existence of legislation, advocacy, implementation. And they have, like asbestos, construction workers, mining, for ionizing radiation, uranium mining. So there are various various, area of work where people are, frequently exposed to this, risk factors. So coming to the occupational determinants, these are the industry where people are very frequently exposed to the various carcinogens, various pollutants, so that they are more at risk to develop lung cancer in the future in comparison to the normal population. And important to name is bartenders, ceramic industries, coal industries, construction industries, glass industries, painters, rubber industries, truck drivers, traffic police are more prone to develop lung cancer because they are, exposed to the external environments, and where the air pollution is an important risk factor, these people are more at risk in comparison to the normal population. These are the suggested reading we have nicely summarized in our paper published in TLCR about the feasibility of lung cancer screening in developing countries. And we have talked about the challenges, but this is an opportunity, and what should be the futuristic way to solve this issue we have nicely summarized. This is the again publication in TLCR. This can be a suggested reading for people who want to understand better environmental and occupational determinants of lung cancer. We have, tried to, talk about all the environmental factors, different occupations, and different legislation in different part of the world. So take home message is lung cancer is largely preventable disease. Most of the risk factors are known, so you can intervene. Screening can save lives in high-risk individuals. Low-dose CT scan is only effective screening methods with mortality benefit. Environmental and occupational risk factors are becoming important, especially in developing countries. Lung cancer screening at community level is resource-intense task. So behavioral modification with tobacco control and a smoking cessation are the only effective modality to reduce incidence. And nowadays, as we know that, air pollution is an important risk factor, we need to make people aware about the hazardous, effect of the air pollution. So if I talk about my country, India, what is the status of lung cancer screening in India? I must say there's a long way to go, but we have to optimist as an oncologist, and we must find every opportunity, opportunity in every difficulty. And it's no point being pessimist who sees the difficulty in every opportunity. So, to conclude, I will say the I in illness is isolation, and the crucial letters in wellness are we. So, we have to be hopeful because health communities have hope, and those with hope have everything. So, with these words, I would like to request everybody that if you are at high risk and if you're a smoker, please go for the screening because it saves life. And apart from that, every oncologist should be responsible for making people aware about the tobacco use, tobacco smoking, and they must practice the behavioral modification in their clinic along with teaching the normal people or the general population about the hazardous effects of smoking on their health, and particularly in the lung health. And apart from this, environmental awareness is a very important and very crucial, and it is of utmost important when we talk about the developing nations where air pollution is an important risk factor for lung cancer. And as per the estimate, overall now air pollution is killing 7 million people worldwide, and most of this burden are from the developing nations. And if I talk about India, there are approximately 1 million deaths, which is now due to the air pollution. So, with this word, I will request you to work together and collaborate together and to do some meaningful work in terms of lung cancer care. Thank you.